Hey, how you doing?
Good, how are you?
Good, good.
All right, so we have a lunch and learn speaker today, and Tim, I'm going to turn the floor over to you to get a little introduction, but Alex Summer is the CEO of Astia Health.
Astia Health.
Astia, and is here to explain what they do and a different approach to medicine, but do you want to give any addition to that? Because you've been dealing with them.
I'm going to be walking out after lunch, so there's nothing to do with the presentation.
No worries.
Thank you for that.
Appreciate it. No second guessing.
We started talking when, I don't know, at wrestling.
Yep.
5 years ago?
Yeah.
4 years ago, something
Yeah.
like that? Just about a different approach to kind of a new way to look at medicine. And we found it very intriguing, and the insurance companies, we spent some time with these folks, and we're going to be implementing their stuff at some point in time here in the future. We've learned a lot about, we can talk more about this afternoon, but just about the whole concept of a broker and what that means. And these guys, the way I say it is, I kind of developed this thing that what I've learned is there's a lot of tentacles and or offshoots, and you really need to be looking at all the different components of healthcare, and they kind of specialize, their niche, if you would, is in some selective things that everybody could implement. It's not anybody in this room could do it, could implement this stuff. So we think that there's some definite money to be saved and some, I think, improvement in service on top of it. So.
Right. Yeah, so we just start with introductions. And so Alex Summer, CEO, Astia Health. I'm an emergency medicine physician by training, and I know a few people in the room. Thanks for having us again, Tim, for inviting us, and we're happy to be here. I mean, I think, it's been 4 years since we started talking about it, but I think we just found our employer, this is where we need to be in the last year, and we've really kind of grown our team. So I trained in Milwaukee, moved up to Wausau in 2005, and worked at Aspirus Wausau Hospital and helped develop their helicopter program for them and their EMS system. Joe and I worked as him being on EMS in Edgar, and then spent about 10 years there, kind of got in the executive level, got on some medical executive teams, kind of realized that, nobody really wants to go to value. There's no incentive to go to value for anyone who's a purchaser of healthcare service, whether it's an insured person or it's an employer purchasing for their, for their employees, right? I mean, that's one of your biggest high dollar business items is healthcare service, right? And we experienced that as well. So I got frustrated with the way things were done, and kind of like a lot of docs, kind of get burnt out. There's not enough physicians in this country to take care of our population of aging baby boomers, millennials, and the rest of us, Generation Xers and below. So, looking at an EMS type model and technology, trying to figure out a way to marry everything together was sort of the impetus. Justin and I are related, he's an attorney, he's my brother-in-law, and I was going to leave medicine altogether and we'd get into more in technology and 3D design and software development. We decided to marry two together because we have both very heavy healthcare-minded families. Why give up all those years of training? We can make it better. I mean, so that was energizing. So that was kind of the beginning back in 2015 where we started building our product. It wasn't until last spring where we started bringing some major players in central Wisconsin that were part of executive teams that really helped us develop the right approach and refocus our model to work more finely with employers, develop relationships like we like to do with our patients, and make it all patient-centric and high value. So we'll talk more in a minute about that. Let the rest of the team kind of introduce themselves quick.
Yeah, Justin Slacky, as Alex mentioned, I'm an attorney, also his brother-in-law. I do come from a very healthcare-minded family, and I didn't want to go into healthcare at first, so I ended up going to law school, becoming a lawyer, and then, of course, I ended up focusing on health law and disability law, so healthcare never really left me anyway. So I have a good amount of experience from the regulatory and compliance side of healthcare, and then back in about 2015, I was talking with Alex, and this opportunity arose with Astia, and ended up deciding that I was going to kind of leave the firm that I was working at in St. Louis, which is where I was based out of, and came up to Wausau and decided to really try to launch this from the ground up. And it's been a wonderful experience, and as Alex mentioned, the pivot that we've done towards employer solutions and really working with employers as well as their employees and their dependents to really offer a value-based approach is what really excited me about this. And again, marrying the technology with that value-based approach is what allows us to do that. With that, I'll shut up and turn it over to the star of the show.
Good afternoon, Ginger Wolf, newest person to the Astia team, but kind of off of Tim's introduction and what you heard Alex and Justin talk about, my career primarily has been the last 25 years working on solutions to help employers deal with the healthcare spend. So I cut my teeth, if you will, with Blues of Wisconsin on the employer. Really have carried the employer flag my entire career under business development and client retention for helping Blue Cross, Wisconsin Physician and Services, which is an insurance company out of Madison. And then most recently, the last decade, a little over a decade, I was with the Marshfield Clinic Health System. But still within the Marshfield Clinic Health System, my job was to help find the healthcare solution and spend solution for our commercial employer clients, whether you were small business, large business, self-funded, fully insured. Had discussions certainly with Alex and his team and some of the executives as I was an executive at Marshfield Clinic Health System, kind of watching, because again my charge was trying to help solve that problem. I was really excited to be able to come join the team because I do think it offers the highest value in helping with that healthcare spend, and there's some real good innovation as to what Alex has done and what the team has done to say, here's how we can help with that. So work with brokers throughout the state, throughout the country, different self-funded TPAs throughout the country, and just was a great opportunity to become part of this team and help lead the development here. So really appreciate the time and introduction to be able to be with you today.
I think there's a lot of stories to tell. We want to focus on our kind of core business model and talk about maybe a little bit about the tentacles like Tim refers to, and maybe hit the technology towards the end and some opportunities there for maybe businesses to maybe invest in the technology piece. So the name of the company actually is the Greek goddess of hearth and home. We just changed the phonetic spelling in case you're wondering why we named it Astia, H-E-S-T-I, and changed it over, and so that's trademarked. We wanted to build something where we could reduce the barriers to access and optimize the value for patients, so patient-centric. So how you look at it, right? How we want to access service. So, when you ask systems, how is the access to service? The response is pretty typical. That's great. There's no problem. So, bet most of at the table here, if you called your primary care provider's office, on average, it would probably take, depending upon, with a practice, up to 20 plus days to get an appointment, right? And some have some various form of virtual models, usually not the same provider. And they outsource that kind of thing. So how do we really improve that? And if there's not enough physicians or providers or NPs, which is becoming more of the primary care model, then how do we really make it better? So we're trying to optimize that. We found our way talking to healthcare systems and kind of talking through our face. It really wasn't resonating. They didn't want to save money. They wanted to make money. The docs liked the idea. So we kind of we really need to regroup, and we're really getting the most traction as employers. And we found that out by working with people in the community. Like I was just on my phone talking to another business owner in town. She calls me up, needs somebody taken care of in the family, and I just take care of it. That's not access you get from a system. So how do we build around that and make it better? So we use an EMS concept, which is called community paramedicine. So, Joe's in EMS, so we use those providers better. So it took a while to convince malpractice carriers and commercial insurance companies to cover service, whether self-funded or fully insured. So I'm still a director for EMS for about 6 different central Wisconsin EMS services, and we take those people, our community, from the community, and provide them tools and technology to basically provide service like a PA, an NP, or a physician would on-site themselves. That's really how it boils down. And then, the service lines we provide right now are employer focused, so it's primary care, near ER level service, and we can tell a few stories that'll kind of highlight what this means. Occupational health, whether it's DOT or hearing screening, vision screening, hazmat, whatever the case may be, ventilation for masks and respiratory fit testing, the whole gamut. So there's a lot of talented people that are nurses and paramedics and EMTs that can do some of the skills that we already do. And that concept is not entirely new. Community paramedicine actually started in Minneapolis and by a couple programs there as a way to really kind of prevent elderly patients from bouncing back into the hospital. For the best example is congestive heart failure. So making sure they take their medicines, they have medicines from the last 10 years, the right medicines at the right time, make sure they don't get sick, they eat the right stuff, and it doesn't cost the healthcare system $17,000 in admission. So, but if you take that concept, and I train people to do critical care procedures you see in Grey's Anatomy or shows throughout the week on prime time, put in tubes in their neck or airways in their neck or tubes in their chest, all that stuff that you really is needed at a critical time may or may not improve outcomes. So if they can do these critical things, why can't we teach them to do stuff that's pretty day-to-day, using technology, doing procedures, lacerations, splinting. A lot of these people do this stuff anyway in different capacities, whether in a clinic setting, in ER, urgent care, and the EMS community. So, but people are really, right now there are 300 protocols for medevac to do all these things on their own. They're not supervised. They're trained ahead of time and trained annually to review cases, but they're not reviewed in live. So we developed our platform to allow us to do that. And what does that mean? So there's like 3 different workflows we can get into in a bit, but so we have, the one we use with them is what we call direct care. So we build cases that are mobile, that go in a clinic setting, in a mobile setting, and they take with them to the point of service, which is usually now more employer side, and they can pull up high fidelity cameras through our platform, through a PC setting, and so we can do exams. We do very, what do we use the most? Web camera, otoscope to see in ears. Moms love that because they can see the infected ear, and a general camera. We can look in the eyes, look at a skin rash, and then we use a digital stethoscope. So all high fidelity stuff that's as good or sometimes better than in person. So it allows us to be right at the bedside when they're seeing patients, and then we can better resource manage. Does that make sense? So that now we can take these people, and they're kind of like us, they're our hands, and now we can see every patient with them, make recommendations, and then so we actually see every patient that we take care of through our platform, whether it's, and I can see them here in the parking lot because we have LTE, and we use low bandwidth to be able to pipe back through the cell towers via the internet back to see patients, whether they're in the Milwaukee area, they're in central Wisconsin, and it's the same interaction as if we were there. So we started this in Marathon, small town, as a sort of a direct-to-community urgent care. Now occupy a former healthcare systems retail clinic in central Wausau, where we do basic point-of-care service, strep, mono, urine kind of testing, and the clinical side. And now we're in the employer solution space, where we ironically we're in a commercial contracting space right now. Merrill Steel is our first major on-site clinic client, where they now have a full beautiful clinic on site and a mobile vehicle that is an ambulance we take and actually take used ambulances, retrofit them to be mobile clinics and urgent care clinics that are powered by both the direct installation of the vehicle with our video system as well as case runs, so we can try to, why install 2 systems? We can take a case into one and go back in the clinic later and use that and see patients there, or take it to the home. So that's kind of the overall model. So we teach them not to do critical care procedures, but to do laceration repairs, toenail, ingrown toenail resections, abscess, incision and drainage, splinting, and foreign body removal. Lots of things that you would go to urgent care for. Tick removal. Those are things we all see, seasonal or respiratory treatments. So they do what their trained skill level is, which is a nurse or an EMT or a paramedic. Incidentally, I just passed a certification for community paramedicine this past summer through the state for additional certification. So you'll see this more and more as the country needs more resource. But that's sort of how we pair the two together. And we spent about 1.5 years, 2 years developing the technology solution, which is both software and hardware, and married it with a clinical model that no one else uses in the country. And we built a fairly robust model in central Wisconsin, including a mobile, a really complex hospital-based kind of lab that no one else has in the region, provide as much service as we can at the point of care so that we can take care of patients quickly and get better outcomes. I'll kind of stop there right now and see if there's any questions.
And I just passed several pieces out, but I wanted to, as Alex was talking, some of them speak to the technology. So the on-site Health 2.0, I'm going to go into some of these each in detail for you, but it's speaking to the case that Alex was referring to. And again, I think what makes us different is, to boil it down, it really is providing the most efficient, cost-effective access to quality healthcare. I had to boil it down in a nutshell. That's really what we're about. So again, I'll go back to what Tim said. There's so many tentacles that certainly we can help clear that fog, if you will, as to just straight to the source. Very transparent. I think, Tim, I'll maybe look to you for support on this. Part of what you're talking about there is maybe some insight as to costs that you didn't know existed before necessarily, right? That you were maybe spending that no one was transparent about, or what the cost of certain things were, whether it be some of that broker stuff or the cost of different healthcare pieces. We tried to make that more transparent.
Yeah, it's like an onion, right? I mean, there's all these layers involved that you're buying a total product, and somebody gives you, hey, here's your analysis on your employees and their dependents. Here's your risk. You know, here's the services they use, and then there's all these different service charges from both the broker, you know, through specialty pharmacy carve-outs, pharmacy benefits, primary care, you know, emergency services, inpatient hospitalizations, all that stuff that you really don't, it's hard to understand. So part of what we do is kind of help navigate, I think, and then with the executives on our team, we're how do we find best solutions, you know, from A to Z to, you know, to really optimize the savings for employers. I mean, it's a win-win for both our model and then what you're looking to do as an employer trying to save costs on healthcare expenditures. I think that's huge. And you know, I'm very energized to dissect that layer, and I went to, you know, I've gone to conferences. Direct primary care is a big piece, which is, you may have heard. Anyone heard of direct primary care? It's kind of direct contracting.
I do.
So that's kind of the big thing that I think that starts the whole equation, is we've seen this separation of primary care providers. They used to be really well respected, and now it's nurse practitioners, and everyone wants to be a specialist, right? So if I have high blood pressure, I go see a cardiologist. If I have a lipid disorder, I go see a cardiologist. If I have an ulcer, I see a GI doctor. Whatever happened to primary care, right? So there's no relationship. It's just this fragmented system of different service lines, adds to cost. Nobody's really kind of watching your overall health. You end up in the hospital, the disease isn't controlled well, the touch points, access points are few. And so how do you make that better? And direct primary care is one of the biggest foundational pieces. You know, as Tim and I have talked multiple times, you know, we're looking for brokers that are really kind of, you know, how do you show us some ideas that we can really find some of these savings and peel these onions back and really kind of be transparent with employers and show them where their costs are. And I think that's really important. So we do direct care, which is because we offer so much more for service. So we don't call it just direct primary care, but basically it's a subscription-based model away from fee-for-service. So as a provider, I don't have to order a test based on utilization or attempting to make revenue, right? That's how healthcare system providers work right now. They're based on revenue. If I'm a doctor working for, whether it's Freighted or UW Health or here local or Marshfield or Aspirus, I mean, most of those employed physicians they're paid on the unit base that they deliver. So, and we've all probably been to one where it's 15 minutes and you're out. So, you know, and your annual is maybe 20 minutes, right? And it's hard to get in. So they get paid based on how many patients they see, and then there's quality metrics, and can you keep your diabetes controlled, or hemoglobin A1C to 7 in all your population. So that's how they get paid. I don't like that model because I think it just incentivizes profitability. So we call it profiteering in healthcare. So that's bad, I think, for employers. It ruins our economy. It ruins the chance to thrive as a business, right? Us and you to thrive, to grow, when you have to really look at your benefits and say, healthcare is huge, pharmacy's terrible. How do we get to the root cause of the problem? So that's what we're trying to do. So our providers, we have a kind of a group of mid-level providers. What does that mean? PAs, nurse practitioners, and physicians. You know, smaller group, about a half a dozen or so, some remote that live in Milwaukee and see patients in central Wisconsin, some of us local. So we kind of have a hybrid model. We see them on site and we see them in the field. It can be us on the on-site clinic doing an annual, or it could be myself in a home, or it could be a paramedic in a home. But you can kind of see how we're trying to resource allocate. So maybe one NP, if you say had 5 branches of your company, you could see every single one using our model in those other locations. So there's many ways you can kind of Lego brick the model we built, but it's based on that relationship-based service. So how do we get to know our patients? If they want to stay with their doc, that's great. We can still save you money based on utilization of medications, laboratory studies, imaging. So right now our service line in central Wisconsin includes x-ray, ultrasound, procedural-based things, workman's comp, labs. We do all these things for Merrill Steel. Everything we charge is subscription-based and is passed through to the employer. They're about a 300-member company with a satellite location in Missouri. We also have our second client is Schutte Metals Inc., so another metals manufacturer. Now everyone there is struggling. You have growing, aging workforce. How do we keep people there? How do we prevent turnover? We think the same way as you do. We don't want to lose people because it costs a lot of money to replace them and train them. So this is another value add. We've heard Schutte employees say to our employees on site that, hey, you know, this is one of the reasons I stay here because we have an on-site benefit. And so the smaller company, 100-member company, typically not really a target for an on-site clinic. Usually it's, we're going to cut it off as 1,000 is usually the number you hear across the country. If you don't have 1,000 employees, I don't want to have anything to do with you unless you're going to bring a group together, an aggregate to get to 1,000. We can do it much less, but so Schutte is an example of a 100 employee business, 94 roughly, 150 belly buttons or dependents that we provide service to twice a week for 5 hours for both urgent care and primary care. So we have a wraparound with them to do mobile and virtual services as well. So again, I'll kind of stop there, but that's where it all starts. And then Tim talks about tentacles. Well, so how do we take it to the next level from us? How do we make MRI cheaper? How do we make CT cheaper? How do we make surgery cheaper? How do we make pharmacy better and cheaper? I mean, that's kind of on our radar. We've already brought pharmacy to the bedside. Example, maybe a couple clinical examples will kind of illustrate what we do. I think that helps a lot. So our very first patient was an ear infection, but this was 2016, March 7th, I believe, when we first launched. We got everything in order. We have everything's cloud-based, so provider in Milwaukee can see everything I can see in person, whether it's EKG, the electronic medical records, sending in prescriptions. So the very first patient was a mom with about 4 or 5 kids in Knowlton, so about 20 miles away from Wausau, where their providers are. So in December 2015, they went to the emergency room. Child had about 4 or 5 had an ear infection, cost them $650 just for that level 3 basic visit in the ER without the prescription. So it's winter, right? Terrible weather. Moms don't like to travel in that kind of weather with 3 other kids. So $700 roughly for just an ear infection. It's a quick look, 2-minute visit, pharmacy, home. And there's a lot of value there where mom has to grab the kids, bundle them up, take them over there, and that's not accounted for. So we sent a truck there, same time at night at the time, and provided service on site. We saw the ear. I was in my home office, so in Marathon, 20 miles away. We did the entire.
What's on the truck, Alan?
So a paramedic was in the vehicle and was able to take our hardware and software, look in the ear, did an entire exam, heart, lungs, eyes, mouth. We have testing on the truck, so we could have done a strep if the kid had a sore throat, but we just did an exam. And then the prescription was actually dispensed right in the driveway. So mom had prescription, never left her house. We can go in the house too. Some moms like a clean house. They don't like us inside their house, so we'd do it in the truck, that's fine. And it was under $200 for the entire visit. Another example on service level is a football field. They get pretty brutal in 3rd, 4th grade now, tackle. So, I happened to be there, and we had a truck there, but quarterback gets slanted on by a lineman, breaks his forearm, has another elbow here, mom freaks out, let's call the ambulance. Screaming, dad's a coach, it wasn't me, but, and I'm like, we can take care of this, so we splinted it up, we drove to the clinic, you got one-on-one care, provided sedation in the office, reduced the fracture there from an elbow to straight with a splint, had the orthopedic surgeon on the phone, sent images to the orthopedic surgeon, they reviewed the images, that's a great reduction, we'll see him in the clinic and follow up next week. So you got all this stuff, ER admission and EMS activation all avoided. I mean, just an EMS visit alone, just to go and take your vital signs and leave is about $600 without any other services provided. And so we avoided that transport. We avoided an ER visit, which probably would have been an orthopedic consult. So all told, it's a guesstimate, it's probably $6,000 to $10,000 visit. So, we did that for right around $1,000. Give or take, and that was fee for service. This is before we did a subscription-based direct contracting model, but that's all included in our model when we do a subscription-based value service. So that's another example of high-level service provided one-on-one. We also do a lot of local work comp, so we'll send our medics to Edgar's, a couple Edgar employers that use our service on an as-needed basis, or farmers in the area that have immigrant farm workers where they need lacerations repaired or crush injuries, and so we take all that remote, like x-rays, lacerations, our medics or nurses fix all that stuff. And the cost is less than half because we don't charge facility fees. That's just fee for service again, not direct contracting. When it's all in one and it's a you know, a monthly subscription-based model. All that's included, and anything we buy or purchase is sent to the client or employee based on the benefit plan at cost. So, for instance, a prescription or a strep test. So they have a value-based model. The strep test is $1.72. That's what the person pays, $1.72. Now, there's other things that get into the model when it comes to federal law and you know, what defines insurance, which is another conversation.
High deductible health plans, things
Yep.
like that. But if you have a qualified high deductible health plan, can you have it be free of charge? So some of our employers that have high deductible health plans say, we don't want to risk the IRS saying, no, it doesn't qualify for that, so we'll charge a minimum of $1 or $10 or they pick it. So an incentive for the employees to use our mobile, virtual, or on-site clinic to make sure they're in compliance with their health plan, if you will.
Right, so yeah, you pay what's called fair market value, right? So a copay, so it can be whatever you want, but it has to be some sort of fair market value level. Now there's laws in Congress and the state here to get rid of that and declare direct primary care as not insurance, and that would go away completely. It's just a risk tolerance for companies to decide what they want to do. The IRS is most likely not going to chase you down retrospectively, may say something moving forward. Soon we'll not have a say in it altogether if the state lays down those rules. So that's kind of what we do in a nutshell, and we've done other things. We've done sedation. One of the ones everyone kind of likes is the Looney Tunes example, where you know, on a Sunday during a Packer game, you know, Dad decides to throw Junior on the snowmobile and without a helmet and drive around the yard with the snowmobile, 3-year-old. Happens to hit his head on the steering column. Big trouble with Mom, right? Laceration between the eyebrows. So he gave us a call. We went to the home and the child was on the couch watching Looney Tunes, where we provided sedation intranasal without an IV with appropriate monitoring at the bedside and stitched up the laceration, which you couldn't see a year later because we followed up with the child and other family members, and it was done right in the living room without no drop of blood on the carpeting or the couch, and right in the home. And that's a kind of example that kind of shows what the power of the model could be. And then if you look at other tentacles within that, you know, what are the high value targets? I mean, that's sort of like a military approach, right? What can we take on and what can we really bend the cost curve on? And then, you know, we have some things in the works with some mobile imaging companies, and there's so many things that can be done virtual that are non-procedural based in healthcare that, you know, you really see a lot of opportunity. We're now refocused just on direct contracting, but we're trying to, that's what excites me, is the vision down the road, is what does it look like after we, you know, start to grow here, we add more value to the equation. And again, MRI in our market is $2,500 to $5,000. So some of you may be aware of the Appleton Smart Choice model, where you can send an employee there, or you can go there yourself and it's cash out of pocket. Can be applied to the benefit plan for $600. Some of those are starting to crop up because healthcare systems are starting to take notice. State of Care invested in them. You know, hey, we don't want to miss the surgeries down the line. So that's the next part of the equation, is what happens when you have a knee MRI and you know, there's a torn meniscus, or we need to do a scope or remove meniscus, stitch it up, or we need to do a knee replacement. We don't want to miss out there. So that's bundled surgical options, where we can, hey, you know, here's the price. You walk in the grocery store or retail store, go to Amazon, I know what I'm paying, this is what I'm paying at checkout, that's it. That's what bundle pricing is, right? So, you know, it's up to the provider or system or whoever, whatever entity is providing that bundled service to make sure that the infection rates are super low, people get good service, you know, they recover well and they're back to work. So I pay, say, $15,000 for a knee replacement instead of our market price in central Wisconsin of $60,000 and $90,000. And that's a big chunk. So total knees and total hips are like high on the radar of high value bundled options that basically can be cost contained. And if you look at one of the leaders, one of the orthopedics, you know, innovation comes from the private sector. We all know that, right? The federal government's never going to give you a handout and say, we're going to fix it for you. We're going to fix your healthcare. It's not going to happen. So an orthopedic surgeon named Keith Smith started an ambulatory surgery center in Oklahoma that does bundle options. So, and all their prices are on the website. I urge you to go there, put Oklahoma Surgery Center in Google, and here's the body part, here's what my employee needs, and then you can incentivize your employees to go there. That's kind of what we're looking to do local too, so people don't have to leave central Wisconsin or Wisconsin at all. Eventually, that would be the model. So again, that's those prices, that's $60,000, $90,000 down to $15,000. So I buy bundle, knee parts for the knee. I employ all my own staff at the surgery center. I bring other surgeons in. Our infection rate is 0.1% or lower, and everyone gets, we pay for the hotel. 3 days you're in, you're out. David Conterno was a broker that Tim talked to, gave another story of himself in his own market in North Carolina, I believe, where he needed a hernia repair, inguinal hernia repair. They do those things there as well, so more and more things are becoming bundled. So his local systems couldn't even give him a price. What does it cost to do inguinal hernia repair locally? You finally got to someone, it was anywhere from almost $10,000 to $70,000. So, he eventually called his friend Keith Smith. We go to Oklahoma. It's done for, I think, $4,800 all in. And so, that's just part of the technical system that we have. And now we're trying to tackle pharmacy. And some of that's, the government's, hey, don't let people import drugs from Canada. I mean, I've wrote prescriptions for people that have gotten some drugs in Canada. I think 2-3 patients already saves them $3,000. On a drug I buy myself, Walgreens, I think it's about $865 a month. You get the same drug, exact same quality from Canada for $65. So, I mean, there's a lot of gouging going on, and being part of the system, nobody's really doing anything about it. So anyway, so that's kind of the energy and the stories behind what we do. I hope that kind of sets the stage. We feel like at Merrill Steel, we're part of their wellness program. That's a huge opportunity for us. Whereas systems in the past have come in and said, hey, your lipids are high, your blood pressure's high, your blood sugar, you're pre-diabetic. Go see your doctor, lose some weight. That doesn't work. They come back a year later, guess what? Their numbers they grow and grow and grow and get worse. We're there, we spent some time with them, when we're starting to work on what I'm going to like here is an employer prescription for life, which is really a multidisciplinary tech-based provider, trainer, that kind of thing all in one, where you can really make a dent on that instead of giving everyone Lipitor or blood pressure medicine or a diabetic medicine. So really relationship-based, patient-centric, whether it's our tech piece. So we just have a lot of touch points in there. So I'll kind of stop there and see if anyone wants to add anything or ask any questions.
So I just want a little bit of clarity. So I know you have the online service, and then, so are you basically doing providing and the health insurance, or is this besides having, because we're not self-funded, we're still the other way, only because for us to go self-funding is going to cost us more money at this point due to our usage percentage of a 1.2.
Your risk factor.
Yeah, our risk factor is off right now. So it's not, we look at it every once in a while, but it'll cost us more. So is this more based on the self-funded plans or the fully funded plans, or is this run side by side with your health insurance?
That's a great question. I was going to pause there too and go around the room because I would love to hear from all of you as we're going through. And again, hopefully Alex gave a good intro and we'll go through some of this stuff. But precisely to that question, again, some of us with hats saying we want to be able to solve the cost problem for large employers. Or as Alex mentioned, it's not to knock the quality of healthcare. Like I said, I came from Marshall Clinic Health System. Alex worked for Aspirus, which is a regional. Healthcare is regional. Our job is not to just stay in central Wisconsin either. Our goal is to help lower the cost of healthcare, up the quality of healthcare, up the access of healthcare wherever we are, and working with those regional systems for that. Along that same vein, if you will, it was we don't want to be able to, we want to be able to help a small employer. I don't want to have to say to you, unless you have 1,000 employees, we can't help. Or unless you're self-funded, we can't help you. Literally hot off the press was, how can we help that small employer that can't go self-funded? Because the answer isn't self-funding for everybody. Right. And there's regulation, there's a lot of things that may prevent you from being self-funded. How can we bring some of this model without having on-site or other employers that have multiple locations? Where do you put your on-site? Things like that. So that's kind of what sparked that innovation of our mobile. Our mobile was there, and our virtual, which we should have brought a case. We didn't, but we'll see if we can pull up the app. I don't know if there's a way to connect with Mark.
We probably can, yeah.
To show them how easy it is to access. I mean, I would love to be able to demo just from our app.
Yeah. I don't know if you can hook up to a video on there.
Connect for a small employer.
I can just pull my phone too.
Fully insured. You still pay a subscription service. We have to look at, again, it's regional. We can't just bring a truck to where you are because it still costs us money to hire that in. But we're looking at launching just a mobile virtual service. So you can't have the on-site, you pay a subscription fee, but it automatically gets you all of your employees and their family members access to our truck that Alex explained. We can go to the ball field if your kids are there or your employees' families are there, or we go to their home to fix the laceration when they're on the snowmobile, things like that. So a smaller subscription fee brings our fully insured smaller employers, the mobile and the virtual
Because
services.
our insurance currently, the insurance company that we do have, they have the online services that connect to physicians.
Yep.
They don't have the mobile part where you would go to their home or to the ball field. So I'm familiar with the online service of
Yeah.
just, dialing in, talking to a doctor about your issues.
Like
And
teledoctor.
they can send a prescription over and stuff like that, yeah.
Yeah, we're talking about kind of the whole package, so, kind of dovetail what Ginger said is, maybe we can get you to self-funded by our model, and that's one option too, right? I can't guarantee it, but maybe all the other things we do makes it, more likely that you can be self-funded and take the savings you get annually into your pocket instead of the carrier's pocket. When I started this model, I'm like, it's gonna take a while. There's a lot of barriers here in this country on getting solutions out there, but I really believed when we started doing it that this is the solution to solving a lot of our problems. It's just that, no system, which now owns docs, owns hospitals, owns insurance companies, wants that to happen. They just don't.
I think, part of what makes us unique, again,
Maybe Maddie can do a demo.
Some of the perception is that
Maybe you
we're
have to be
going to
Maddie
take out some
or
of the larger
Marathon.
systems, right? I mean, we're not in existence to try and take down the big guys.
What do you want to
Part of what I'll talk to when we get to
Maybe
more,
Lisa.
okay, there's a solution for you as the employer, where the employer had write the checks for your health insurance. So now you gotta write a check for your fully insured plan, then you're gonna
Is
write
there
out a check
internet
for
to
the
the TV?
health pension. The longer term play is helping you overall
Where-
costs down, and that hopefully you see that in your premiums and or being able to go self-funded, right? Just the well population, so that's a longer term play. But the other side of the organization, if you will, and part of where investment and technology helps us grow also as an organization is we have the technology we have and a partnership that's recent. I gotta pass this around because we're literally down to our last one, but I wanted to show you part of what I'll start this one way and that one that way. Is we're able to actually go in front of some of these larger health systems. So I'll pick on Freighter because they were the first ones to come to the table and say they see value in the technology piece. So we can private label our solution. It looks, feels, smells like Freighter and their TPA.
Hey, can you please do a demo for the
and
entire
medical
office here,
college,
the executive room?
But it's us behind the scenes, if you will.
For me?
So we help
Could you grab,
training,
so basically be in front of the entire
a big part of our
Vistage
shtick, if you will,
lunch
as
and learn.
Alex mentioned, is you don't always need
So if you
an
wanna
MD.
grab the-
You don't need an MD on your onsite, right?
You ready to
You don't
go?
need an MD, and it's not click on Teladoc.
Just turn it on, grab somebody to examine, and I'll be waiting.
To
me. Thanks, bye.
You've got paramedics and MAs in our clinics. So some of our onsites are initially staffed with MAs, medical assistant, paramedics. And then if they need to link to Alex, who's the MD, or they need to link to Mark, they can take care of some of that stuff virtually. So it's what I would refer to in my career as practicing up to that licensure, if you will.
And what's cool about that though is you can go wherever you want. Like, I was at
It takes them
practice.
everywhere. Yep.
Yeah, you guys took your kids where, Joe and Tim had their kids for wrestling is kind of where we connected and point. So, at times I've seen 3 to 5 patients in the parking lot during wrestling practice on my iPad. And then the providers are, whether they're in, Wausau or Schofield, Merrill Steeler, at Shooty, in Kronewetter or Marathon. I think, we can do that from anywhere, which allows you an opportunity to get better providers, and not having to move to a different location of the state. So allows a lot of opportunity within the platform to provide more access. So we're going to do a demo here in a second. So the platform itself, again, was built for patient-centric type of environment where, if you wanted an urgent care visit, like you talked about, the virtual, that's how people know virtual or telemedicine, really. There's kind of a lot of terms that kind of seem like they're similar. Right.
Nurse lines that have existed
Right.
for a long time too. And I want to finish my thought too on the Freighter thing. So again, we're
Yep.
not here to take out the big systems. It's a regional play, and we all have our place, right? But also why it works is the Freighters of the world. Some of these on-sites that are with this health systems, I will pick on central Wisconsin, which is where I'm most familiar, but the Aspirises, if you will, or the Ascensions, or frankly Marshfield Clinic. If they're going to put a nurse practitioner or a physician assistant on site, typically their whole motive is to drive it to their system, right? And the the more they do, the more they make, kind of thing. Where we can come in to still, it's very regional, so we get a pulse with, okay, Freighter, here's your footprint, UW, here's your footprint, Dean is Dean. I mean, you guys are all over the state, right? So, you know, it's a very regional thing. Up where we started and were home offices for us in Marathon County and that whole central Wisconsin, it's 3 systems, 3 big systems, Aspirus, Ascension, and Marshfield Clinic. It's not to knock them, but we're agnostic to all of them. We want to just lower the cost of care, get them the best access and the highest quality of care. So put us anywhere and we'll work with any of those systems, if you will. Some of it, the insurance carriers, if they happen to own the health plan, kind of like where I came from, there's some conflict, but we're working through that. So we've got some contracts with TPAs. Exceedent is the TPA that is part of the Freighter family. So our pilot, that piece that I just passed around, that they private label, we just started the pilot. We're weeks in. Obviously the goal is to grow and be at multiple employers within that before the end of the year. But they saw value in saying, as a system too, there's value in having additional services we can provide to our third-party administrative clients. So we're on-site at employers that they actually have through their TPA, which is very transparent. That's not a full insured product. But we can bring better healthcare, if you will, and on-site and everything we're talking about, the value of the healthcare piece and what they're purchasing to some of their employers as part of their health plan. So there's a lot of, that's some of those other tentacles, still all with the mind of higher value, lower cost healthcare.
Yeah, if you look at that, at the pilot study, one of the big selling points at the executive board meeting we had with Freighter last October was that if you look at, Ascension said, hey, we got to stop building biling hospitals. We have to move into the ambulatory space because that's where it's all going. It's more cost effective to do a knee in a surgery center or do procedures in a surgery center than a hospital. And rural hospitals are, kind of drying up because we want people in the hospital. We want them out of the hospital. You get less sick, less infections, get better quicker. So, that was kind of our pitch to them is, we're already in the ambulatory space. That's where we live. That's where we work and operate best, meaning in non-hospital-based, non-facility-based locations. You're in the middle of a Oreo cookie or a Vice. You got Ascension on one side, and you got now Aurora Advocate, which joined with Advocate in Illinois to be one of the biggest system and the 10th biggest system in the country, and they're in the middle. I train there, so a little bit preferential to the quality of care there. It's the only quaternary. It was the first quaternary referral center in the state, so they get everything, right? Kids, adults, with every kind of problem, transplants, complex heart disease. So that's where it kind of all started. And to me, their experience. So, hey, you are a smaller organization amongst very, very large national players and regional players. This is an advantage. And so for us, to me, that's a great brand to be a partner with. And so that's kind of where we're starting. But how does that work? Well, right now we have, there's supposed to be up to 5 in the pilot. Right now we're starting with 1 very motivated small employer, about 100 people, 100 employees named Letterhead Press in New Berlin, where we're doing on-site services for them. They get, there's a list of menu services we're doing. It's not as complex as Marathon County. That's just kind of where they wanted to start and see what the utilization was going to be, how much cost savings there was. But it does really, it is independent, it is dependent on employer participation within how you drive participation of engagement and use of your employees and their spouses. How do you incentivize them? Do you, like down there, we're doing some free clinics, blood pressure checks, right? I mean, come into the clinic, meet the provider, see the system, and then they use it more for urgent care stuff. I think there's a lot of stuff in medicine you can do without hands-on that you can do virtually. I mean, if you have a blood pressure cuff at home, I can change your blood pressure medicine easily remote if we're relying on information more than just urgent care, right? So we're supposed to be doing a demo here, but I'm waiting for Lisa to log in.
Just to add to, what I see as a WIO official too, it's amazing how the hospitals have put staff at all these sporting events now. And it's amazing how different trainers talk to different athletes and how they encourage them. I mean, you talk about it's a direct link to these facilities. It's a great idea. It was a great move on their part.
Blame them for that.
Right.
Exactly.
And the coach just washes their hands of anything.
Right.
They have no liability now.
Right.
And these trainers are funneling all these kids into these facilities.
Yeah, whether it's that or it's primary care, a lot of times they're seen as loss leaders that get them into those high expense things like the labs, the imaging, the surgery.
It's crazy. I just shake my head.
And just go back to what Ginger said too about that we're system agnostic. We're not just picking the lesser of, in our case, 3 evils. So it's, okay, well, Marshfield is a little bit cheaper than Ascension, which is a little bit cheaper than Aspirus. Sometimes it's not even going to those systems. Sometimes it's working with local doctors, local surgeons, who have their own independent practices. There's Novo Health, which is up in the Fox Valley, which is a conglomeration of different doctors who perform various types of surgeries, whether it's orthopedics or whatever it might be. And it might be going to them because they can offer bundles that the hospital systems just don't know how to do or are not willing to do. So when she says we're agnostic, it means sometimes they might be the choice that might be the best choice. Sometimes they're not, and none of them are. So we really don't have any beholden, loyalty to anybody there. We work completely independently for things that we can't handle. We send it to the best possible place, the best possible value.
So let's just boil it down to what we're here for today, right? So it's two things. One is clinical solutions for employers. So again, we appreciate the opportunity to come talk about a broad topic that can, so now they're doing a demo for us here. So providers are notified via cell phone, via SMS, and then hopefully things work okay. I have one bar here on LTE on an iPad, so I'm going to try to make this work for you.
Sorry to put you on the spot for that, but I thought that'd be a great, I hope that's okay.
They do have a guest network too.
Yeah, I'm on it. We'll see how it works. 2 bars.
So while he's bringing that up, I did pass out a copy of the slides. So this, again, speaks to more of our private label. So when we talk about the freighter pilot and or me knocking on Marshall Clinic Health System door, frankly, say, if you don't want to collaborate, as again, the Astia tech side of the business says we can take this to other provider systems that maybe just have the phone call right now. They don't have the full complete solution.
Right.
We can bring that extension to them as part of their business where no one even needs to see that it's Astia Health, frankly, because they want to be able to carry their brand. That's also what we're doing across the country with other systems.
Yeah.
The company that you just talked about has about 100 employees. Do they pay a monthly fee to you?
That's a pilot is unique. It's set up through Freighter, so it's paid direct per visit. So, right now we're assuming that we call near site and far site providers. So near site providers are the providers that are located next to the patient, and the PAs, physicians, and NPs are the far site providers. So in that model, it's a pilot. So through October, we're hoping to onboard more clients in that pilot and see more patients because it shows that we
But the end game
can do that, right? Yeah.
Yes, everybody pays
Right.
the same subscription fee.
That's what we prefer. I don't prefer a fee for service. I think it's bad
They were
disservice to
trying to
everyone.
blend it in, if you will, to their, sorry Alex, they were trying to blend that into their TPA administrative fee schedule, if you will. So here's what you pay for claims admin, here's what you pay for the pass-through. There's different pieces, if you will, when you buy third-party administrative services for the health insurance if you're self-funding. So part of the Freighter Exceedant pilot, to your question, was how do we cover the cost? And as an added value to their TPA, they were looking to see if they could bundle it in, if you will, to their administrative fees. So we're still working through all that, but end game would be, we nail this down, we know how it works. Cheryl at Letterhead Press has been one of our absolute biggest cheerleaders. She loves it. We're on site there a couple times a day, doing all of it and the virtual stuff. So it's nice to have some of those partners that, like Merrill Steel we talked about, and then we have another smaller clinic. They converted a restroom on site for that 94 employer metal manufacturer we were talking about. Key is to have champions at the employers that we can see how things work based on what the demographics are, but it all gets to a subscription-based model for what those components are.
So,
I mean,
Ready to
what,
go?
a fee per person,
Per
month.
member, exactly. So
and there's a fee for service above and beyond, or no?
I think she passed around, well, it's a pass-through cost. So say you need...
for that one,
Yeah.
the lab, the $1.72 strap,
Right.
that's where you'd see some only additional fees for some of that stuff.
Or if you cut your arm, you came in, or you had a injured worker, it would be, you pay for the sutures or the Band-Aids. Some of that stuff we call, it's is just, is really low-cost stuff. It's kind of like, disposables. We're not, throwing those in there. But, some of the splinting material is expensive, so, we weren't sure the risk would be on that. And, if Johnny falls down every day, it gets kind of costly for all the material. But you still pay wholesale, so whatever we buy it for, that's what you pay.
So if I got 50 employees, I pay you so much per employee per month,
Exactly.
and then it costs a pass-through.
For
Yep.
some of those lab and crutches or, exactly.
Right, and it doesn't go to the employer, it goes to the benefit plan. So whatever, say, for instance, and obviously it depends on the carrier and it's fully insured. It's why it's easier for us to do this on a self-funded plan. And not that we can't do it on a fully insured plan with the pass-through stuff, but it gets a little more sticky with accumulators towards deductibles. And again, the self-funded stuff, it's easy. We call the UMR or Oxyant or the other, or Exceedant, and hey, that's gonna apply. So you buy crutches, it's towards your whatever, $3,000 deductible, or your splinting material.
But we can drop it, so
Right.
we're billing. We do all the, it's all compliant, so there HIPAA, there's certain claims that we're required as a provider to complete, so the TPAs that we work with and have contracts, or the fully insured carriers that we work with and have contracts, it's all the same standard coding and billing.
So we figure if we're gonna expand, that we're gonna need to be flexible in how we bill. A lot of direct primary care practices don't bill insurance at all. You don't get a claim, it doesn't go through you have to pay the separate fee, right? And they say, well, I'm gonna prevent hospitalization, so, 70% of your cost is from admissions, yeah. Yep, no, that's actually me, so they're gonna do an exam of a patient in Merrill Steel. So we just basically jump on iOS app and then we'll call in and show you how that looks. And sorry, it's a son and a small screen. I will, yeah. Yeah, so then.
You guys, we just had another appointment.
Yep. So I'll just let Lisa show you how this works. She's our chief nursing officer, and I will go close as possible.
Yeah, no, thank you. We have a 1:30 and then another 10 o'clock.
What's that?
No, I just didn't know if you had any glare.
No, there's glare, because we're not in, I doubt it, I don't have a video signal. Hopefully she's gonna answer the phone, so. So they set the screen to available, and then if they have to run and take care of a patient while I told them 1 minute and it was 10 minutes, let's go back to the thing here.
I got a lot of migrant workers.
Keep going.
Well, I had a guy actually on last Friday, come to me, big swollen face.
Are you ready for a case call, or we're all sitting here waiting?
So I got Alex's cell, so I call Alex, hey, I need some help.
That doesn't matter. Let's just do the cameras, please.
With a guy other than take him to walk-in, they have a bunch of money, so.
You can just do the case. Just do the case. Take it off the TV.
Facility, they got him some medication to get rid of the infection on him.
We have to have it plugged in and have it on AC power.
He had his tooth yanked, but.
Do the wall one then in the second room. Exam room 2 is fine.
Expensive to take him to an ER.
Just throw a walk into the ER.
Yeah. That's the big-
It doesn't matter. Just bring up the,
Kind of distill what our mission and our model is, which is about providing access.
you have to set it, in the browser, and then you have to set it bottom right, you have to set the speakers to echo canceling speakerphone.
It's the local walk-in or it's the ER.
So for $100
Okay,
bill.
you ready?
The medication.
Can you start a new call?
Swelling's taken care of, the infection's gone, and cash is wonderful, the dentist, $200 yank his tooth out. So if that would have been an insurance deal, it would have been $1,000. That's what a mess our insurance, that's how corrupt it is.
$200 better than it was.
No, yeah.
hang beef in here.
Yeah, so, we didn't warn them there was a demo, so why don't we talk about the technology piece a little bit? Well, Justin, while we're warming up here, so.
Yeah, we started that. So there's also a PowerPoint that we wanted to leave with you today. Again, I've mentioned it speaks to the private labeling that we're able to do. So part of the technology is the case, and I'll let Justin take it from there. But it kind of walks you through. There's some pictures actually of how the technology works and the cameras for the virtual piece. But again, how would another system use our technology, and where are we going with that?
Yeah, so as Ginger mentioned, so we have a case, it's a telemedicine case. And when you think of how care was delivered, say, 70 years ago, especially in rural areas, it was the doctor would go make house calls and he had his black bag, right? So we've kind of taken that into the 21st century now. So we have still the black bag, our cases are all black, but they incorporate our platform to be able to deliver the care and bring the doctor right in the house, but doing it in a virtual way. So the cases, when you open them up, they're about 29, 30 pounds, same as what you'd probably bring, a carry-on luggage. Yeah. And I think you all have this brochure, the On-Site 2.0 on the back. You can kind of see the layout of the case. So you open it up. It has a computer screen. It has some cameras on it, so it's going to have a general webcam that allows for general interaction between the provider, the patient, and, as Alex mentioned, the near site provider, that paramedic or that nurse. open up, and it has other diagnostic devices, which allow us to do a full virtual exam, just like you would do if the patient was
Dr. Summers.
doctor.
Hi, can you guys hear me? Hello?
Hello. So we're going to go ahead
We'll just go ahead and let them do a demo here of how the video works.
and show what the ear cameras are. Oh, that's beautiful. Hello, everyone.
Hello.
Let us give us a second to get situated, make sure everybody can see it. Can everybody see? Okay, we're good. Thank you.
The inside of Katie's right ear right here.
So what am I looking at?
The inside-
So you're looking at the inside of somebody's ears. I don't know if you guys can tell. If you want to,
So diagnostic.
you want to focus it. Yeah, you want to focus it on the.
But it's perfect time, that's what Justin was just talking about, there's the kind of
Then
components.
we'll go ahead and look at Katie's left ear.
So you're looking right there at the middle ear bone,
Beautiful picture.
and then the light's shining off the tympanic membrane, and then you can tell if there's fluid, if it's red, there's pus, or if it's perforated, if the tympanostomy tube's in place, and she's having
Now
some.
I'm going to do a head exam looking at eyes, nose, and mouth on Katie. We also use this camera if somebody has a cut, a skin rash, anything like that.
There's three heads. One's the general camera, one's the digital otoscope, which you just saw. The third one is a digital stethoscope, so it allows them to better be able to hear all heart and lung sounds.
Oh, she's using the. There you go. Yeah, I don't know if you guys can see. Sorry. They're having a speaker issue.
Can you open up your mouth and say,
So just like in the pictures on there, we have like.
beautiful.
That's good. So we will pick up with them later. So then we do the stethoscope exam. We have screen sharing built in here, as well as text messaging and camera switching for devices.
We also have a digital stethoscope that we use to listen to heart and lungs right through the computer. And this is used many times so that we can order a chest x-ray. They can actually hear crackles, wheezes, different lung sounds right through that. And then once the exam is done,
Just
the
don't double
provider
text.
lets us know what tests need to be ordered.
it.
And many times we follow up after. So if there's an x-ray, we do a shared screen where the provider actually pulls the x-ray digitally right up on the computer.
Okay.
And the patient can see it, and then they kind of show them what they see, if there's any issues or concerns, or if it's normal.
Okay,
And that's it. Thanks all for watching.
Thank you.
thanks. Okay. So the application itself, both on a mobile side and PC side. So we built it for iOS, for Apple, and we also built it for personal computers, whether it's a Mac or a regular PC. So, excuse me. So one of the other things we wanted to talk about is kind of as I'm trying to troubleshoot the tech here, is the technology piece. As we enhance that, there is an opportunity, we kind of talked about this yesterday and today, that there may be some interest and investment in the platform. We developed overseas. Now we moved to the US a few years ago. We'd like to upgrade that, add additional features. What do we need investment for? Well, so we talked before about teledoc kind of thing, where you call and you get your urgent care services. So, this is the provider side of things. There's also a patient side that, Justin, I don't know if you have your device ready on a patient login, you can show them quick what that looks like. So basically, providers make themselves available to patients, and then you can schedule. If you just
You can
do.
all download our app.
Right, yeah. I'll quickly show you what that means, but so the physician or PA, or we have telemental health providers as well, behavioral health is becoming a big issue as part of the total package. Make appointments available so then you can schedule at home, at work, wherever you want to see those types of providers. Our urgent care pathway, we designed kind of like an urgent care ER where you call in, you press a button on your what's called Get Care Now, you go to a nurse or a triage provider, they see you virtually, get all your information, bring in the doc or PA or NP as a third party, and then they drop off the call after the introduction is made, so you don't have to wait anymore, you're just constantly handled by a person as you move through the process. So that's the urgent care pathway where you call in for the pink eye, the bronchitis, the rash, like I said, even primary care stuff. We think you can use that pathway, say in healthcare systems, as a white label to triage the entire system. So we built a couple referral centers for Aspirus, it's called Physician Connect Line. They had a similar system in Milwaukee at Freighted, where all their inbound hospitals and clinics would send patients from. You could see how video conference dramatically improves the ability to assess patients, which enhances the platform. So you can integrate that within what Freighted Health does. So one of my goals, which is exciting to me, is to build the platform, make it better. Freighted Health uses Epic. Everyone familiar heard of Epic in Verona? They've kind of owned the EMR, electronic medical record market. So it'd be ideal for us to integrate with them. Freighted Health uses Epic. One of the ways to leverage integration is to have clients that obviously pay for the service. So that would be another use for investment funds, is working on what's called HL7 or fire interface integrations with those systems, so that they could use our platform and within one window. It makes it easier for the doc or the provider to do. So also within the platform which is on the slides that's going around, and you can see the appointment availability on the front of the smaller one. It's also in the, yeah. Do you have that? I gave that to you.
I do not have that one. I have.
So that basically shows you where you can make an appointment. It's on our application too if you want to download that. Whether it's phone, video, or on site, you can pick your time, and that sends an alert to the provider via text message that, hey, was a patient to be seen at this time. No HIP information is released, so they don't know what your condition is, what your name is. It can be sunk to the device's calendar, and then provider knows that there's a patient to be seen at X, Y, or Z. So integration is one big thing to enhance the platform. We've talked about our wellness solution and increasing touch points. In other words, one of the ways you could probably solve a lot of problems is having access to your provider, if you could text them right away or send a photo, they give you advice. A lot of people just need advice when you access service. Where do I go? Who do I see? What do I need? Maybe it can wait. Maybe it's something simple. Maybe it's workman's comp, it's something simple, or it's, and then there's more social. We talk about incentivization or gamification of part of wellness and as part of access points within our platform. So there's a lot of opportunity there for us to grow that in a more robust solution, to offer more solutions to you and your employees and your dependents.
Ready to do a time check.
Yep. I think I just want to leave the rest open for Tim questions or anything anyone else want to touch on.
Well, I mean, it's straightforward.
Time's valuable, so if, for you anyway.
Tim, you're working with them now?
We were in the process of, it's more of a complicated. What happened, I guess what I've learned from a personal perspective is I kick myself in the ass for how stupid we've been in buying healthcare for years. And we bid every single, over the years, you've worked with Candace how long?
Long time.
Since you've known her what?
Since day one.
Okay, so you all know Candace, who runs our association services. You've 20 years? 25 years that's known each other. And we've always gone out and bid our healthcare aggressively every year. But what I've learned, you only know what you know.
What you know.
Okay? And we're stupid. We are so stupid as a company. We have been pissing money away like it's going out of style. I can't even, it just makes me sick to think about how much money we spent.
Let's not get excited.
But I'm talking about, I personally believe we will reduce our costs of health care. We had 1.6 million in claims, and I'm going to say we will save at least $500,000 with what we're going to a year. And that's how bad we're buying health care, and we're bidding it more than, I know for a fact, the amount we bid was way more aggressive than most companies. So I'm going to guess the majority of companies out there are worse than we are. Okay? So what you have to do, what I learned was, you got to help me. We were with, let's see, Willis,
yeah.
and then they sold to
It's a
Ansay.
different brokerage.
It's a brokerage deal. Okay, it all starts there. It kind of starts in this broker category. Well, the
Pick your
problem,
partner wisely.
well, yeah, but the problem is that, and you know, the problem is, as you get into this, you have association service or human resource people doing your bidding for you. And they kind of all know each other. And guess what? They kind of don't know what they don't know. So what I've kind of figured out is there's about 15 components to a healthcare system. When each of you have a healthcare that you offer your people, there's like 15 components within that. And what you're doing, what you're all doing, I'm going to guess, is just what we were doing, is we were going to Willis, and Willis would bid and come back with a spreadsheet, and they'd get all this stuff and they'd lay it out. Well, here's the problem. They're going to Ascension, correct? And Ascension, of those 15 components, is providing 10 of them. And my brother's wife, her job at Ascension, she works for Ascension, and her job is to internally incentivize Ascension people to refer people to Ascension. That is, she's 100% paid to, and everyone that refers a person within Ascension gets paid a commission on the referring person gets it, and the person that receives it gets paid. That's how they get paid. All systems that we're talking about in central Wisconsin are like that. So what you need to do is you need to have an accountant should be bidding your health care. That's the first thing I learned. We should never have had a person in HR dealing with this stuff because they don't understand what questions ask because they don't follow the dollar. It's easy to spend other people's money. Okay? So, and they're not doing, don't get me wrong, they're not doing anything wrong. They just don't know what they don't know. Okay? So the first thing you gotta do is you gotta pick a broker. And we've interviewed now, I've personally interviewed 7 different brokers. There is only 2 that know what the hell they're doing, in my opinion. I mean, all the other ones are exactly the same. They talk a big game. They all are dealing with these tentacles, and they have all of their eggs in one basket, and or they're getting backside money from every single one of these people, and they're getting paid on the backside, and they're not doing any of you a favor. None of them. What you need to do is you need to go out and find a broker that is willing to bid all 15 different one of these components, and it doesn't matter where you're going to get it from. Okay? For instance, all of you should have an international pharmacy broker. Okay? It's really simple. Any high-end drugs that any one of your people are on should be coming from Australia, New Zealand, England, or Canada. Guaranteed, probably 10 cents on the dollar cost. Okay? So you have to...
If you're self-funded.
If you're self, yeah.
The only problem with that is the government and the FDA are trying to regulate importation of pharmacy for personal benefit. Big surprise, right? Because, you know, PACs influence the FDA through pharmaceutical companies, and PBMs, and it goes back and they're trying to prevent that. So that's great. So annual cost increase is 6 to 15% a year, right? Self-funded or fully insured. So if you take their regular crony-based discount of $100 per unit of healthcare annually, and you offer a system-based discount of 2%, you're $98. What if the price starts at $80 and you get rid of the 2%? That's where the crony stuff starts. So the math is just funny math.
Fuzzy math is what I call it.
Funny fuzzy math, right?
Yeah, but you can get some of those drugs for 10 cents on the dollar.
Right.
In those places. And what you talk about, this Lake Norman, this David Genturo, he gives an example. He says, you get a person that's on a drug that's $5,000 a month. I'll just give you a quick example. And you can go to, let's just say you can go to Canada and you can buy that drug for $200. He goes, so I'm gonna put the guy on a plane, send him to Canada, tell him to take his wife. I'll put him up in a hotel room for 2 days. He can go buy his drug, and there's an international law that says you're allowed to carry 90 days supply of a personal drug over borders because it's a prescription. So I'm going to have him bring 90 days of the stuff back. Give it to me. I'll administer it, and we're going to send him to Canada 4 times a year. And guess what? I can drive his costs down 30 grand a year. And that's savings directly to the organization.
Or the other way to do it is, so the brokers are limited by what the brokers can do, right? They don't provide healthcare service. Or you can go with, say, an innovative healthcare company that can actually direct where the prescriptions go, even outside of the benefit plan if they have a high deductible. And pharmacy is just the biggest shell game in the nation, in my opinion, and very hard to follow cost and where cost goes. So your pharmacists or your providers within systems send prescriptions electronically to Walgreens, Walmart, your local pharmacist or whoever else for oral prescriptions, and IV stuff gets shipped to the hospital because they can increase the cost. So, we send prescriptions to a pharmacy, Northwest Pharmacy in Canada, which resources from credible sources that have FDA backing quality, and just a couple patients, scripts went from $3,000 down to like $50. I mean, it's unbelievable, so I send the script over, they get it. So, so we can kind of quarterback the spending and not to, but so bending, there's a lot of opportunity there, right? The broker can now open giving us new channels to outsource specialty carve-outs, what they call, for say Remicade or Humira, if these names sound familiar to you, or Cocentrix. We're looking at some of those for our clients right now to try to save $10,000, $20,000 a month drugs and get those to, at least 0.5% to 1% lower, because you got these guys that are just we're manufacturer to patient that are just grabbing chunks of money along the way.
Explain the coupon thing.
Yeah, well, so, yeah, so if
I could never have guessed this is going on.
Yeah, the biggest clamshell game, right? So a pharmaceutical company, what do they want? They want you to get to use it. They want the doctor to prescribe their drug, right? So I don't care what drug it is. Say it's $20,000 a month versus something less expensive. So, like, holy cow, I want to use that drug. They say it's great on the TV, the commercial's awesome. Everyone's happy, healthy, got a great family, it's perfect life. It's like Facebook. So, they'll give you a coupon, a rebate, you go to their site, you qualify.
They give your employee the coupon.
Right.
Okay? They don't tell you about it though.
So you're the payer as the employer. Well, it's self-funded or fully insured at some level. So you want so pharmaceutical companies, they want you to use their drug, right? So we'll just take care of the deductible or build it in down the road, and then so the first month the patient then gets the drug. It gets either baked into a fully insured plan or a self-funded plan. You're paying the whole thing at some level as the company with the bank account funding.
Your employee gets a coupon for $1,000. Okay, so his deductible is $1,000. He takes it to the pharmacist, and he doesn't pay any deductible. He thinks this is great. It's freaking free, isn't it? Guess what? The company's paying the $20 grand. Okay, that's how they keep the guys. So what they do is they send a coupon. They find out who's using these high-end drugs. They send manufacturing coupons to their house. The guy takes it and he doesn't know your company's paying the bill, and that forces. And he thinks this is great because I get a free drug and then I get to see what's on television. And the company's sitting there paying $20 grand a month, so they never even consider a generic. You have to get rid of that. You got to take it.
Yeah. So there's a lot of ways to do that, right? So first of all, not everyone that plays a violin is healthy and happy on television, right? We all seen that commercial. And do you need to be on the drug? Is it indicated? I mean, we're not trying to steer people away from good medicine. That would be very bad for our patients and employers and their dependents. So is it indicated? Can we set a formulary that's generic? And we do have pharmacists in the background are trying to build a pharmacy benefit into what we're offering employers. So how do we get, what's the best drugs based on best evidence base? Where can we get them from? Are they sanctioned by the FDA, the American Heart Association, et cetera, for all these common conditions? And then, you don't use these generics, and we don't want to sacrifice quality, so there are some brands that are good. And then we find places where we can get them less expensive. And then we bring them in, we find solutions where maybe we can prepackage them and give them to you for wholesale, far less than what you're paying when you go to Walgreens. And the savings just accrues over time. Instead of paying an extra 6 to 15% annually for your total cost, maybe that's 6 to 15% less. Now that would sound good to a bottom line, wouldn't it? I see a lot of faces that are like, really, that's how it works? I mean, it really does work that way.
I've learned.
That's one of those
I have literally learned more about every single meeting I sit in. And I had never, up until now, I have never sat through one of these, meetings to bid this. And how this happened was, we were with Willis. They sold their book of business. We were with Willis. They sold their book of book of business to ANSIC, and we just decided, okay, if we're gonna do this, let's not just accept ANSIC, let's just kind of go to bid. And I said, okay, I've never done this, I'm gonna sit down. That's how this happened, I got lucky, okay? So I literally sat in and listening to this, and every meeting I started learning something.
You were asking
And I'm starting to ask questions, I'm writing notes, and then going, this doesn't make any sense. I said, you're kidding me, these are the costs. And then we found this guy, this David Contrero,
Concerno, yeah.
And you heard him speak. By far the most interesting. His company, this company, and you can look it up at the internet, super interesting. They're owned by the Hill Group, H-I-L-B, okay? 2008, took 3 guys to get together, they said, healthcare sucks in the United States, we're gonna fix it. So they have a model that they're gonna go out and acquire very aggressive insurance brokerages, okay? They started 2008, they didn't have anything. Last year, 160 million in sales, 63 locations across the United States, but here's the interesting thing. 100% of those 63 are being run by the private owner. All they did is acquire and continue the owner in the position. So they've got a company, they've built a company in 8 years across the United States that is now the largest privately held insurance brokerage firm in the US in 8 years, but all of their company is being run by people that were business owners.
Yeah.
It's a very unique model.
And their model is really based on one thing. They call it the Health Rosetta model, which really just is a name for all the things we've just discussed over the last hour. And what I liked about David is we went to the Healthcare Economics Summit meeting, and my team didn't believe me. I'm like, I like people that are gonna, we needed somebody who's gonna really rethink the way we're doing this, because it's not right, and it's not right for me, my family, and we've turned family members around that have been near-death experiences into that basically have been written off and stuck in a nursing home. And his dad would have probably died last year. He's gonna be 90 this summer, and we got him turned around, and it's just a matter of touch points and access. I was going to a conference in Milwaukee, and had all the traditional speakers, American Medical Association, the Medical College of Wisconsin dean, and they all spoke, and then John Torinas from Serigraph, who was my brother's first client, talked about wellness and how great it is. And then you got somebody who comes in from Lake Norman, David, and basically just challenges everything they just said, and they were just green, pale, and I loved it. I'm like, not that they're bad people, it's just that, this is the same thing, you're just rehashing every year, and there's a better way to do it. I'm not saying that there's not great providers and systems, there are. It's just the way they deliver service is kind of screwing over patients, employers, and their families year to year. So that's how we got started on David himself, and I just like the way he thinks. Now, if you can bring all those ideas and make them better, which is what we're trying to do, why I'm excited is, there's a lot of direct primary care companies in this country that are really catching on, and some within the state of Wisconsin, but I think what separates us is, we were lucky enough to develop relationships with people that know what the hell they're doing, to be blunt, and to get people that have been in the systems in the state for decades, and know the inner workings. They're excited about the model and value model as us. Ginger was Chief Sales Officer, John Kelly was the Chief Operating Officer, was our strategy guy for Security Health Plan, and worked for Gunderson and Marshfield Clinic for decades, and then our other numbers guy who was actually, up most of the night working on different,
He's our dad now, so we've got some great...
just amazing actuary, masters in health. People are just excited about how we're trying to do it.
He came from Aspirus.
Yeah, from Aspirus' executive chain. Right, so, and there's more that are interested, and obviously we feel the vice in central Wisconsin from the 3 systems. There's not a lot of love for what we're trying to do, because it basically just pulls money out of their pocket annually. They are the biggest employer in central Wisconsin, right? So anyway, that's kind of the story. I think, we're just happy to be here and looking to work on growing our brand, work with other employers, small to large, as well as develop our platform, make it more robust.
So in the end of the day, these guys are going to probably fit like 2 or 3 of those 15 tentacles, to be honest with you. Mm-hmm. That's what they're a piece of what I've learned is that you need to be bidding all of these things through a broker, and you have to have transparency, and you also have to have a contract that says they're not allowed to take any money on the backside whatsoever. And there's a way to do that, okay? But I guarantee you, every single person we were doing something with, in my opinion, had their hand in the cookie jar and was getting a piece off our backside, and we never knew it.
And we'll actually do this, and part of it's because of my background too, but helping employers and having that. But we're not connected and we're not commissioning brokers, if you will. So we're not going to pay you on lowering the cost of healthcare, right? So some of that can get us into maybe a relationship with Tim or something, or you all, but we'll be direct to employer, whether the brokers can figure out that this is a good solution or not.
Yeah, that's pretty evident, but I think that the other
And truth be told, is just of all the brokers that we've talked to, there's only going to be about 2 of them that want them involved.
Understand.
They don't want them involved.
Right.
Okay, they actually have financial reasons not to do this.
Yeah.
This is like really, you gotta completely rethink
It's different.
the way you're looking at healthcare. And I just learned it just by, and I just want to bring them in and say, hey, I mean, I look at how stupid we were as a company and the way we
Well, you run your
combined-
business too, so it's, I mean, you're hiring someone.
Yeah, trusting people that aren't changing the way they're thinking of things. You know, I think what's exciting for us though is, and more examples, is other tentacles are my vision for. I want to grab those and change those.
They're within reach, yeah.
Yeah, they're within reach, and then these guys, you know, say, you know, we're doing too much. You know, it is there. So I've taken care of some of these patients that need an MRI. You know, we don't have a mobile MRI model up in central Wisconsin. So where do we send them? They typically would have gone to Aspirus, Marshfield, or Ascension. You know, got their $5,000 MRI. But I'm like, you know, hey, Mr. Employer we work with, you know, are self-funded. You know, why don't we try to incentivize this? There are some that pay, you know, here's $200. Drive to Appleton, 4 hours off, you know, IRS travel time. Come back, you know, cost us, if they met the deductible, $800. It's a self-funded company right now, plus travel, where it would have been 5,000 local. So just look at the savings. So we direct them there, and then we have one that needs surgery. So market price for surgery is probably close to $10,000 for a knee scope for a meniscus repair. So I know I got a price. There's other docs in the state that are willing to get involved. They just don't know how to do it. And so like reaching out to surgeons and saying, hey, can we work on an arrangement to maybe be sort of shrewd like Tim and other of you have been at the table with your business, and hey, can we buy some surgery time at a surgery center for,
practice good medicine.
right, they want to take care of patients that way, and there's ones that are willing to do it. So I got a price of under $4,000, 3,000 some dollars to do a knee repair that otherwise would cost local
By
10.
phenomenal.
Yeah, by top-notch guys. These are not, I mean, we've done quality studies on there. We don't want to send people to people that don't know what they're doing. So if I want,
Well, Alex, you see that eventually this maybe it puts some pressure on some of these local facilities that they're gonna
Yes.
have to bring their price down because they're
Right.
gonna lose.
They're gonna
Eventually people
I mean,
talk
that's,
about it.
right, hopefully that's, again, we're not here to take them out, we're
Right.
hopefully.
yeah, we need your help to do it though, because you know, we're the enemy to them. So that's the issue here.
But eventually,
Yeah.
Well, they're going to have to cave and rethink how value is delivered. You know, if I can stand someday that made a,
$10,000 for that scope.
why was the last time there's new buildings going around these facilities? There's always buildings going around hospitals because they're nonprofit and they can spend money.
Right.
Because they're making money. So they just keep building and building and building
Right.
and building.
So we should wrap up in the next minute or so?
yep,
I mean, this David, and what they're doing actually is Foresight.
Foresight Civil.
Yeah, I know, yeah, but who's the guy?
Brokerage.
Who's the woman?
Drew.
Drew.
Yeah.
Foresight is a broker out of Green Bay that actually is doing on-site, they have on-site, an on-site in their
They
headquarters.
have yeah, on-site for them, and then it's a near site for
A near
local
site
employers.
for others.
Yep.
Okay, so they're actually they're the only broker in the state that is actually doing it. There's
That's
one.
not
All of them all will talk about it, nobody else is doing it. And then there's Lake Norman, which is owned by the Hill Group. They are actually putting together a proposal that we've been going back and forth on because we narrowed it down to those two, and somehow they figured out that they were both in there. So they're joining forces to come to Wisconsin with a brokerage that is, I'm telling you, it is so different than every other broker we talked to. Is unbelievable. And their approach is so unique. And I can tell you what he said, and just going back to like how you drive the care, David's position is this, he goes, I will only work with you. This is kind of interesting. He says, this is the only way I'm going to do this. I cannot direct care. He says, but what I can do, he says, I can tell you this. Frequency goes up, cost goes down. He says, that's simple. He said, so, what does that mean? He goes, we have to look and find places that will do a lot of knees. They do 5 a day and have no infection, and the lowest infection rate, better than any of your hospitals around here.
High quality.
So high quality, we can prove it by infection rate, and we will drive the cost down. It's that simple. He said, that's all that matters. He goes, you don't need to know anything. He says, take the AS people out of the thing, get the warm, fuzzy, yellow crap out of it. He goes, that doesn't matter, because it all comes down to the higher the frequency, the lower the cost. It's that simple. And infection rates. As long as infection rates are controlled, that's it. So you go to your person, you got a guy who needs a knee replacement. You go, okay, here's the deal. You got a $1,000 deductible, you got this, and it's going to cost you, by the time you're all done, it's going to cost you $3,500 out of pocket, and you can have it done right here locally at your hospital over here. Or your employer has worked something out, and if you go here, and by the way, the infection rate is this versus this at the place you're going to have it done. These guys do 5 a year. These guys do 60 a year, and you can read all about it and everything like this. It's going to cost you nothing. We're going to pay you and your wife to go there, stay in a hotel for 2 nights. You can buy dinner, and it's going to cost you nothing. Take your pick. That's it. And the bottom line is the cost difference there to the company is going to be 30 grand.
That's the knee, yeah, we talked about.
But he said, that's how you do it. It's really simple. You just say, take your pick. He said, the more blue collar your workers, the more effective I am. He says, because $1 to a person that's making $18 is worth more than $1. He goes, my worst clients are professionals. He goes, because they don't care as much. He says, so the more blue collar your business, the more I'm going to help you.
Yeah, it's easy to get these guys to. It's easy to incentivize them. You offer, Merrill Steel or Shooty somebody $200 who makes, I don't know, 15, $16 an hour. He can go to the healthcare system or go here like, holy cow, I'm going. I asked you $200 in my paycheck this week. It's incredible. And it's not an obligation. And the surgery thing, I mean, you can go there right now. You can go right now and go look at Oklahoma's website and, have your doctor refer you there if you needed a procedure. You don't need my approval or David's or anyone else's in Oklahoma, and they have the whole bundle set up for you. They'll help you set up the financing. So just a free tip if you wanted to do that and you had employees that had that, you could say, hey, I'll give you $1,000 to go over to Oklahoma. It's going to save you eventually, $30,000 to $60,000. So
we had an associate, and this is kind of in this whole process.
I'll leave some of these cards here, please.
But his daughter needed a jaw realigned, and it was not covered. Can I just tell you the story? They went to Marshfield Clinic to a specialist.
You want to talk again? Sorry, thanks for hosting us today.
Supposed to be the guru of Central Wisconsin, and they wanted a quote because it was not covered. It was not going to be covered. $78,000. So they came in and he came in and goes, I don't need one. And he wanted a loan.
You got my phone number?
Money from a company. He asked, that's how I got involved in it. You want a loan? And I said, this doesn't seem right. I said, you really need, I said, how many of these have this guy did? And I'm kind of going down the path of what I've been learning. And so we go down we ended up finding a place in Chicago, just outside of Illinois, that the guy did that's the only surgery he ever did. The guy that was going to do the surgery had done 5 last year. This guy does them weekly. They went down there and it cost them 22 grand. He saved $55,000, and this is an associate of ours that makes about 60 grand a year.
Right, that doesn't have.
That's without that. Would have been non-deductible dollars. So I can tell you, this stuff works.